sarcomas can cause something like this. And even lymphomas can present in a manner that is very similar to this. Lymphomas in this region would not qualify as primary CNS lymphomas. These would be extranodal bone lymphomas, where they won't even need high-dose methotrexate in the treatment, and what they will need is cyclical multi-agent chemotherapy, again with curative intent. These are actual cases. This is not hypothetical mental exercise. These are actual cases that could have masqueraded as that. And the danger is having dismissed them as potential bone cysts or benign lesions and with disastrous consequences. Now, this non-neoplastic, it's not even benign, it's non-neoplastic brain lesion left alone, it has severe morbidity and mortality, and all of these that could have masqueraded as left alone would have caused the death to the patient.
Okay. Any questions, any comments? Please.
بأسأل عن الأوفثالميك evaluation لما حكينا إنه الفانكشن of the optic disc كان deteriorated بس الأوبتيك ديسك نفسه ما فيه يقلل ما فيه شيء. سؤالي لأي درجة بنقدر نعتمد على الفانكشن تشخيص السودوتيومر سيربراي أو في الهايدروكيفالس ونشيت التريتمنت بس إذا كان الفانكشن of the optic disc.
Ibrahim, you want to comment?
So we have always this mismatch between function and structure. We have always this mismatch between function and structure. Sometimes the structure tells us about the function, sometimes it is not. So I can show you a frank florid papilledema with good visual function or good visual acuity, accepted visual acuity. So basically what is important is the function, and the function probably goes first, then the structure in some cases, and vice versa in other cases. Actually, was your question about ICP, increase ICP?
سؤالي مرة ثانية عفوا. function كيف أتأكد إنه هاي الفانكشن كانت من الأوبتيك ديسك وإذا تأكدت خلاص يعني I can start the treatment. أنا ما في عندي جراند تيومر في الكيس، في عندي هيدروكيف شاكك إنه هذا is it active هيدروكيف ولا arrested هيدروكيف ولقيت الفانكشن إنه deteriorate.
So basically what you do is you follow up the patient. If the function is deteriorating, that's an active disease. And sometimes you find visual dysfunction and you follow it. It is there for a long time. It is not progressing, and that's why we do follow up.
We'll ask Maurice to answer this question too.
Yeah. One thing that you can get the help of is doing visual evoked responses. Now, if you do a visual evoked response, you can get an idea whether the damage is axonal or demyelinating. Now, I don't know whether any of you have seen a visual evoked response. Basically, you put a patient in front of a screen, and then you measure the time it takes for the image to get to the occipital cortex. You can actually look at the function of the optic nerve, optic tract, all the way back to the occipital cortex, where it is stored. Now, what you will get, you'll get a nice response. Now, if the response is large and delayed, that usually tells you it's a demyelinating. If you get it very small and delayed, that's axonal. And if it is really axonal, then the prognosis is bad, because that means there is damage to the axons. So that might help you in differentiating between the two. You know, I mean, if you have a case like this, it would have been quite useful to do a visual evoked response. And if you find that it is really the actual response is quite big, but it will be, as I expect, delayed and not really much affected by as far as how big it is, then that would tell you the prognosis is probably better. Now, if you find somebody who's really lost the signal, or it's really very small, that will tell you it is axonal, and maybe the response will not be as good.
I want to ask Ammar and Baideen about this. Papilledema and pseudo-papilledema. How can we differentiate, especially for young people?
Simply, both they have normal visual function, and visual field can differentiate, and fluorescein and geography can differentiate. But just one comment regarding the patient. The patient has optic neuropathy in the sense that he has impaired color vision, he was counting finger, so the lesion is proximal to the lamina cribrosa, that is to say the posterior part of the optic nerve. As Maurice said, you can do visual evoked potential to just confirm the presence of the optic neuropathy further, but simply you can do a simple clinical bedside test, just doing looking for Marcus gun pupil or relative afferent pupillary defect. So I think clinically we can tell easier than before going into visual evoked potential.
And sometimes because of the adhesions of the arachnoid around the optic nerve, sometimes the intracranial pressure is not transmitted to the optic nerve to see it by fundoscopy. Isn't that correct?
Yeah.
دكتورة سنة.
طبعا أشكر عمل الفريق بينكما، طبيب العين الحاذق وجراح الأعصاب الرائع. هذا جيد، ونفتقر كثيرا أحيانا في بعض الأحيان في الأردن لعمل الفريق. تعليقي، رأيت في الورقة ذات الموافقة كلمة فوبيا. كطبيب تعرف أنها فوبيا، ولكن هل المريض يفهم ما معنى الفوبيا؟ لماذا لا تعطى كلمتها الصحيح باللغة العربية؟ إنها رهاب الضوء. عندما تقول رهاب الضوء يفهم المريض عندما يوقع على ذلك ما معنى الفوبيا. شكرا.
دكتور عتامني راديولوجيست. دكتور الزام.
كنت صغير يعني احنا لما ندخل انوريزمال بونسيست على طول بيخطر على بالنا الجاينت سيل تيومر. الفرق بين الاثنين تقريبا يعني مش دائما انه الانوريزمال بونسيست يحترم البوردرز والجاينت سيل لا يحترم. سؤالين صغار دكتور ابراهيم. اولا التيومر او الانوريزمال بونسيست هل له وول او ما له وول؟ وقديش نسبة الانسيدنس اوف ريكارنس في الانوريزمال بونسيست؟
The last question first. The incidence of recurrence of aneurysmal bone cyst is 20 to 40%, and there is no border that you can see. It is made of many septations, many compartments, so there is no border that you say I have completely removed it. Especially that it goes to the bone, especially if the bone is the skull base. For Adamni?
Thank you very much for a very nice lecture. My question. You said that the MRI findings, especially fluid level, is pathognomonic. But I think it's not pathognomonic because there are different lesion can give fluid level as giant cell tumor, chondroblastoma, and osteosarcoma. I think it's not pathognomonic, but if you find multiple fluid level with sclerotic or hypodense lesion in T1 weighted with multiple septation enhancing and the fibrotic band enhancing, it's in favor of aneurysmal process.
But if you see bone level, fluid level in a bony lesion, the first differential diagnosis is aneurysmal process.
Yes, one of the differential, yes. Thank you.
Hence, Dr. Atama, what we discussed is the possibility of this having the giant cell tumor or chondrosarcoma or osteosarcoma. These are actual real parts and differential. These were actual cases. It's not a hypothetical what else would this have been. And the importance of the surgical approach in all of those cannot be overemphasized. I can't agree with you more.
دكتور محمود الأسعدي أنت.
شكرا. First slide you said about the way of management. You said the external approach and then endoscopic approach.
Sure.
Just to mention that these things could be in each case we have to evaluate, but it could be done endoscopic without any external approach. Most of the new maxillofacial, they like external, but most of the ENT, they would prefer endoscopic. And now endoscopic has become a very, very wide approach, and we can reach to the skull. The main things for the patient was the eye. And this can be easy when we open the anterior ethmoid, the lamina papyracea will be pushed and then the eye will come. And we have seen, I did many cases, on the spot, on the table, the eye comes back. And with the ophthalmologist with me, once we remove the tension about the lamina, the eye come proptosis or deviated or double vision or something like that. This is just to mention, and it is up to the surgeon in the approaches. Thank you.
So the message from Dr. Muhammad Asad that there is an endoscopy approach for this, which I agree to. My question is, can endoscopy remove such a giant tumor? I say no.
My question is about, was there any lacrimal syringing done pre or post-operative?
I can't honestly remember whether this was done or not. Most likely,
Symptomatic, no symptoms.
yeah, no symptoms. Yeah, exactly. But I can't really, with honesty, say yes or no.
Question: if this recurs, would you go back and do another surgery? Or
Yes.
would you go do an angiogram, do injection?
I would go for surgery.
For surgery.
And if there is remnant, I would think of other options. Surgery is the key for this. Dr. Sazif Haddad, interventional radiologist. Any questions? Okay, with this we finish, and I thank you all. And we will meet next week, at the same time, with a very, very interesting case. It is toxoplasmosis in the spinal cord presenting as a spinal tumor in HIV positive patients. So we will raise the question of HIV, etc. So thank you very much.